Lichen planus. So patient will come with a chief complaint of burning sensation, white lines or patches inside the cheeks without significant discomfort, right? Now coming to history of present illness. So patient will be healthy from 3 months when he or she noticed white lines or patches inside the cheeks, which will gradually develops burning and soreness, right? Then let's come to the examination. On examination, first of all, I will do extraoral, which is I will look for the flat or topped lesions in the skin, right? Uh, Wickham stria, which is the characteristic lesion of the lichen planus, or wrists, ankles, and lower legs, right, will be affected. Also examine the scalp, the nails, and the uh, genital mucosa, right? Then I will come to intraoral examination. So first of all, I will check for buccal mucosa. There will be bilateral and symmetrical lesions. Then I will check tongue, gingiva, labial mucosa, right? And we will see multiple bilateral, symmetrical, white, lacy reticular lines on the buccal mucosa, right? If you see these symptoms on the oral mucosa of the patient, then we can suspect lichen planus, right? Now, differential diagnosis of lichen planus. So we will rule out these diseases from lichen planus. So first of all, ruling out leukoplakia. So in leukoplakia, there is usually unilateral, solitary, and homogeneous lesions, whereas in lichen planus, as we said earlier, that there is typically bilateral and symmetrical with Wickham stria, right? Then comes leukoedema. So in leukoedema, there is diffuse and disappears on stretching the mucosa, right? Unlike lichen planus. Then comes chronic candidiasis. So there will be white lesions which will usually wiped or scraped off, unlike lichen planus, right? Then comes lichenoid reaction. So there is usually unilateral and localized, often adjacent to a restoration or related to a drug, right? Whereas in lichen planus, there is commonly bilateral and symmetrical lesions, right? Then comes the pemphigus vulgaris, which is mainly present with fragile bulla and painful erosions rather than reticular white stria, right? Then comes mucous membrane pemphigoid. So in mucous membrane pemphigoid, there is characteristically causes blisters, erosions, and desquamative gingivitis, right? This is important for mucous membrane pemphigoid rather than Wickham stria, which is the characteristic lesion in lichen planus, right? Now, for investigation, the diagnosis is mainly clinical, but an incisional biopsy can be performed when confirmation is required or when there is an erosive, ulcerative, or atypical lesions, right? There will be basal cells, degenerations, cuvette bodies, or band-like lymphocyte in the pathological report, right? You can also learn these. Now, let's come to the management of lichen planus. So the management of oral lichen planus mainly depends on the severity and symptoms, right? First of all, the first line treatment for symptomatic lesion is topical corticosteroids, right? Such as clobetasol, which comes under the name of Dermovate 20 grams, fluticasone, which comes under the name of Cutisone, and the last one, mometasone, which is a high weight ointment, right? And for severe, extensive, or refractory disease, systemic corticosteroids may be considered. It is oral, right? That is methotrexate, the most important one. That is 1 milligram per kg per body weight, and we will continue this dose for 6 to 8 weeks, right? Then the last one, cyclosporine, which is an immunosuppressant, the same dose, 1 milligram per kg per body weight. This is also for 6 to 8 weeks, right? Now remember that the patient should also be advised to avoid spicy and irritating foods, mainly good oral hygiene, avoid tobacco and other local irritants, and attend regular follow-up appointments, right? Long-term follow-up is important because erosive and atrophic forms of oral lichen planus carry a small risk of malignant transformation also, right? Thank you.